In last week's video, I talked about the conditions you see in primary care, kind of the mixture of what patients you're seeing and the procedures that you do. But in today's video, I'm going to talk to you more about the nuts and bolts of what it's actually like day-to-day working in primary care.
Hello. Welcome.
Normally when I work primary care, I would try to be at the office around 6:30 or 7. Really kind of depends on what time the first patient is scheduled for. I wanted to try to give myself at least an hour before the day starts. So what would I do in that hour? Well, first I would review the schedule of the patients that are going to be coming in for that day. To refresh my memory on some patients, remember where they are in their treatment plans, to see what their last test results were like, if they've had recent labs, if I'm going to have to order new labs for them. And then as I'm doing that, try to pre-chart and fill in lab orders, medication refills if it looks like it's time for those to be refilled, anything that you can get done ahead of time. I would also try to identify anything that I thought that the MA could do when the patient comes in automatically. Like if we have a patient that's coming in and it says, some kind of urinary complaint or abdominal pain, I'm going to ask them to just go ahead and get a UA when the patient first arrives. So that can be already running so that when I get in and see the patient, most likely I'll have the result back already, and that will help me quickly get through the visit. I would also need to go through any lab results that are sitting in my inbox and then write up the directions for the MAs and what they needed to contact the patients and tell them. Of course, if there were any that were some serious results or that needed me to talk to the patient directly, I would put those aside so when I had time to call the patient. I would also go through any medication refill requests that came in, any questions that came in the patient portal. And then if I have a chance and still have some charts left, work on finishing up the charting from the previous day. So I try to get all that done, or as much of that done as I could before the first patient. Now, the patients usually start at about 7:30 or 8:30. It really depends on your practice. Most practices are going to have their patients scheduled every 15 minutes, 20 if you're lucky. These are going to be for established patients. Then for patients that are new patients, or like a Medicare annual wellness exam or a physical, those kind of things are longer appointments, well woman exams. So a lot of places give around 45 minutes for that. Again, it really depends on the practice. Some practices are only 30 minutes. Some will give up to like an hour for those kind of exams. So normally you have a 4-hour block in the morning where you'll be seeing patients on whatever that schedule is set up. And a lot of times providers will work with practices to make sure that their schedule is set up in such a way that they only allow like 1 or 2 of those longer appointments in the morning and 1 or 2 in the afternoon, and try to strategically schedule the other patients to make the day flow a little bit better. Not always possible, but it's something that you can work on. And then of course, practices love to double book those 15-minute appointments or work in walk-in patients. And in order to try to stay on time, you really need to be charting while you're in there with the patient. Some practices have scribes, but the practices that I've been around do not have scribes, so you'll be doing your own charting while you're in there trying to take the history and do the physical. And then, of course, after you get out with the patient, then you'll need to try to get that note done if you can, or as much of it as you can. And really helpful to at least get the medicine sent off and any referrals started so that you don't miss those at the end of the day. Lunch is normally scheduled for an hour. If you're running behind, which happens often, you won't get that full hour. Oftentimes it's like 30 to 40 minutes. And then, of course, during that time, you really need to be charting. If you don't want to spend several hours at the end of the day, you try to get as much of your morning charting done at lunch as you can. Handle any more urgent, patient requests, questions that come in, and any more refill requests that come in. Staying on top of those really helps because if you let them, they will pile up and bury you. So you have to kind of constantly be cleaning those out. Also, if you've had any difficult patients in the morning, this may be a good time to try to call specialists if you need to talk through a case or meet with your supervising physician, whatever is appropriate. So in the afternoon, you typically have kind of a mirror of the morning, except for usually afternoon sessions are normally around 3 to 3.5 hours in most practices that I've been in. So then once the patients are done being seen for the end of the day, hopefully you've got about 45 minutes to an hour of admin time where you can then work on all the other stuff that's been piling up. So in addition to the medication refills, patient questions and requests that come in for the patient portal and phone calls that the MAs and nurses are fielding from patients, you also need to do things like review reports from home health and also from physical therapy, letting you know what the proposed treatment is after you've referred somebody to them, and if you approve that, or if they want to continue the services, you need to approve or deny that. Sometimes you have to recertify patients for oxygen or order durable medical equipment for them. You have to handle things like handicap placard requests, filling out paperwork for physicals, FMLA or disability requests, and service animal requests. So there's a lot of paperwork. You can imagine primary care, you're dealing with the ins and outs of people's lives, anything that their medical health is affecting in their life. You kind of have to dig in and handle that in primary care. A lot of extraneous stuff that we don't really learn about in school that you have to be involved in. Some practices are better than others as far as the MAs helping you with that paperwork. And of course, in some states, PAs and NPs can sign certain documents, certain things, and other states they can't. So you've kind of got to be aware of what's allowed in your state. And then the charting in primary care is always an ongoing thing. That's probably one of the biggest complaints that people have about working in primary care is just the amount of charting. When you work in a specialty, you can do a whole lot more templating in the EMR. And you can set up templates in family practice, but because you see such a wide array of things, it's really difficult to have templates for everything. And then oftentimes patients want to address, several topics while they're in there in the appointment. So you end up charting a little bit about each topic, and that's really hard to do with a template. The other thing that makes it hard in primary care with the charting is that, especially if your clinic receives any kind of federal funds, Medicare funds, things like that, you often have meaningful use objectives that you have to meet in your charting, which just basically means that there's certain things that have to be in your chart. And a lot of those things would be measurable things like A1Cs and blood pressures and things like that, which most likely you'll always be putting in the chart anyway, but also making sure that that it's documented what screenings you talk to them about, what they're coming up due for, what they're overdue for, why they haven't gotten a screening, all kinds of things like that. And sometimes the EMRs will have those things where you're just kind of clicking buttons. Other times you'll have to kind of remember to put that in your chart. So that makes it charting just a little bit extra difficult in family practice. What is the role of the MA? So they room the patient, right? They take the vitals, they get the brief synopsis of what's been going on with the patient, they review the medications, and they kind of get your chart started putting those things in for you. It's also nice when they come out and they give you a little heads up about what's going on with the patient so you know what to expect when you walk in the room. If you have to do a pap smear or some kind of gynecological procedure, they usually set up the trays for you and all the equipment that you need, or if you're going to do a laceration repair, they'll get those trays ready for you, and they'll often sit in with you and assist or chaperone for the gyne procedures. They also will gather the urine and run the UA test, or they'll run, once you swab a patient, they'll run the tests on those swabs and handle some of that back office stuff for you while you're in seeing the patient. They'll also do things with the patient like rumen removal from the ears, or if you do an I&D, sometimes they can finish up the cleaning up and bandaging of the patient. MAs also field the phone calls from patients and kind of clean out the patient portal, handling whatever they can and then bringing the rest of the problems to your attention. Same thing with the medication refill requests. They usually go in and see if the patient's due for a refill, and then put the preliminary refill orders in. That will get sent to you, and then you can approve or deny that or make any changes necessary. So it's really important to have a great working relationship with your MA. A good MA can make you, or an MA can break you. And when you first start out, you want to establish rapport with your MA, but you also kind of want to go over everything and see what's happening, how you can streamline processes, how you can set things up to work the best, so that you're both working efficiently and effectively. So what's the autonomy level in family practice for PAs and NPs? Well, of course, that varies as well, too. There are some offices that are exclusively run by APPs because maybe they're in a rural area and there just aren't any physicians in that area. And their supervising physician is off-site in another town, but they are available by phone. And then, of course, in some states, nurse practitioners have independent practice and they have run their own practice completely. But most of the clinics that I've seen and work in have physicians leading the team, and that's really what I think primary care should be. I know that there are a lot of great APPs that have a lot of knowledge, but we don't have the depth of knowledge that a physician has. So that's the model that I prefer to work in. And in that setup, there's kind of two common ways that APPs can work. One is that they have their own patient panel, which means that you are seeing your own patients. You are seeing new patients. They come to you, you diagnose and treat them, you see them for follow-up, you handle every aspect of their care. And of course, you consult with the physician as necessary, but that patient really belongs to you. Then there are other practices are set up where the patient panel is really all under the physician. They all belong to the physician. The physician has usually seen that patient when they first come in, maybe the first couple of times they come in, and once they're an established patient, then the PA or NP will see those patients for follow-up and do more of the routine things. And then every once in a while, the patient will rotate back through and be seen by the physician so he can kind of keep an eye on their care and how things are going. So if you're going to work in family practice, that's one thing that you want to think about and decide what you would prefer for a practice setup. And then when you're interviewing with a practice, ask how they are set up. So this video was more nuts and bolts about schedule and extra things that you have to do in primary care. Check out my other video if you're interested in primary care that talks about like what conditions you see and what your patient mix is like and what procedures you could do in family practice. I'll put a link to that at the end of this video. So if you really love your specialty and want to tell people all about it, or if you really don't like your specialty and want to warn people about the downsides of working in that particular specialty, I'd love to hear from you. I'd love to interview you, make a video about it, and share that information with other people. My email address will be in the description box below. Well, thanks again for joining me. Stay sane out there, and I'll see you next time on the Medicine Couch. Bye.